Good day to everyone. Um, I'm Sue, your lecturer, Francis Muche Managasale. Mm, we are still looking at mental health and psychiatric nursing. Today's topic is depression, which is unit 3.3 in the curriculum for general nursing. So before we go into details of looking at depression, let's have the introduction part. So as we discussed previously about the two words mood and affect, let me again today begin with the same weight. So mood is a pervasive and sustained feeling that is experienced internally and that influences a person's behavior and perception of the world. So we're saying the mood is actually felt internally. But what you bring out in terms of your behavior, out of how you're feeling, is actually the affect. So the way you present yourself to the outside world is the affect. But usually, the behavior that you are portraying to the outside world mostly comes from the feeling internally that you have. So, meaning there should be a relationship between your mood and your affect. While its affect is the external expression of mood, like what I've just said. So, most times your affect should be congruent to your mood. So, a mood disorder is also referred to as an affective disorder. In simpler terms, depression, just like mania, can be referred to as a mood disorder or an affective disorder. Mood disorders are disorders that involve emotional disturbances consisting of long periods of excessive sadness. Remember the other time we discussed mania, where we said there's actually elation of mood, or there's being in a state of euphoria for some time, being excited for some time. However, depression is the opposite of mania. So we're saying mood disorders are disorders that involve emotional disturbances consisting of long periods, excessive sadness, which is depression, excessive happiness, or elation, which is usually mania, or both. They include bipolar 1 disorder, which we discussed previously when we looked at mania. Bipolar 2 disorder, we also discussed that when we looked at mania in the previous lecture. Cyclothymic disorders. These are more like mild, it's more like mild depression. The signs and symptoms are more like mild disorder, bipolar disorder, so to say. The signs and symptoms are not that severe as in bipolar 1 or bipolar 2 disorders. Then you also have dysthymic disorders. These are mild but elongated. It's a mild but elongated type of depression. That is dysthymic disorders. Then we also have seasoned affective disorders. Now, a higher incidence of depression in women has been noted in many studies, and various explanations have been offered. Women may complain more rapidly of depression than men and may be more prepared to discuss troublesome feelings and secrets. What we are saying is that mostly men, even when they are depressed or they have a topic, they will not easily share it with another person. That's why you would notice that women seem to have more cases of depression than men, because men don't easily open up to discuss their troubles compared to women. Women easily open up to discuss their troubles. Hence, statistics ends up showing that most women have depressive conditions than men. This is artificially created role of the weaker sex and may reflect a socialization process which ascribes to women, especially passive and dependent gender roles. Now, before we look at the other parts and definitions, let's look at the objectives that you students are expected to understand. So at the end of the lesson, you students should be able to acquire knowledge on depression and how to manage it. That's the general objective. Specific objective states that at the end of the lesson, students should be able to define depression. They should also be able to state the predisposing factors of depression. They should also be able to state the types of depression. They should be able to mention the signs and symptoms of depression. Students should also be able to discuss the management of depression. Now, what is depression? Depression is a state of low mood and the aversion to activity that can affect a person's thoughts, behavior, feelings, and sense of well-being. There's a new term there, aversion. Aversion meaning strongly disliking something. So I say when someone is depressed, they get to be in a state of being in a low mood. They have aversion, which is a strong dislike to activity. That can affect a person's thoughts. Of course, when you have a low mood, your thoughts are affected. You tend to have slow thought process. Your behavior, if you're in a low mood, even your affect, what you're going to be displaying to the outside world will be affected. Feelings and sense of well-being will be affected. The other time we discussed mania. Mania is where someone has got an elation of mood. But depression is where someone has a low mood. So in short, depression is simply the opposite of mania. Depressed people may feel sad, anxious, empty, hopelessness, worried. They may feel helpless, worthless. They may feel guilty. They may be irritable. They may feel hate, or they may actually be restless, according to Little 1968. Now, what are the types of depression? There are mainly, understand the term mainly, meaning there are other types of depression, but there are mainly two types of depression. There is what we call severe depression, also referred to as endogenous depression, also referred to as major depression, also referred to as psychotic depression. Psychotic because it presents itself with psychotic signs and symptoms like delusions and hallucination. Major depressive disorder is described as disturbance of mood involving depression or loss of interest or pleasure in the usual activities, with the evidence of interference in social and occupational functioning for at least 2 weeks. So what are we saying? This psychotic depression, someone develops anhedonia, which is loss of interest in the things or activities previously someone enjoyed. This anhedonia and social and occupational dysfunction should at least last for about 2 weeks. Then we can say someone has severe depression or endogenous depression or major depression or psychotic depression. So there is psychomotor retardation in severe depression, meaning that these patients, their thought process are slow. There is no history of manic behavior in the severe depression. So in this type of depression, an individual is unable to confine with ordinary work, domestic activities. They fail to do even just activities of daily living because they are so depressed. There may be severe reduction of movement, which may progress even up to an extent of it being stupor. Suicide is common in severe depression. These guys are suicidal in their thoughts. Hence, when you're managing them as a nurse, you really have to look out for suicidal attempts for quick intervention to prevent that. Individuals often manifest psychotic features like I've already alluded to. These psychotic features are delusions, hallucinations. Accusatory hallucinations are most common. Even auditory hallucinations are very common. They might be hearing unnecessary, maybe voices that are not even there, such things. Another type of depression is mild depression, also known as exogenous depression or depressive neurosis. Exogenous depression, in the sense that exo means from outside. The cause of this depression, it should be coming from the outside world. For example, someone loses a beloved one, or someone has a bereavement. Because someone has lost a beloved one, or has a bereavement, or there is a distortion or termination of the relationship they treasured most, then they risk going into depression. So because the cause is coming from somewhere in the social life, then this type of depression will be known as exogenous. The other name for exogenous depression is mild depression. The other name for mild depression is depressive neurosis. So it may sometimes be referred to as reactive depression because someone is reacting to something that is coming from the external environment. As I have given an example, if someone loses a loved one, the way they will react to that loss, they will be depressed. So if someone gives a history to say, Musonda lost a sister or a brother, then they ask to see, what do you think is this type of depression has Musonda undergone? It's actually mild or exogenous or depressive neurosis or reactive depression. Why? Because the cause of the depression is coming from the external environment. So we're saying this type of depression may sometimes be referred to as a reactive depression because generally it occurs in relation to a loss or any stressful life event. Another example I would give is, here is a child or an orphan, meaning that they lost a parent at some point. Then they become depressed. This type of depression is actually mild depression or exogenous depression or depressive neurosis or reactive depression because they are reacting to the loss of a parent. So the loss may be in the following forms: the loss of someone close to you, for example, a friend, a relative, through death or breaking up of the relationship, just like I've stated, which may occur when a quarrel leads to the termination of a long-established friendship. So those are the major types of depression. So take note of the other names for these types of depression. Usually they appear in fill in the blanks. You may meet a question which states, what is the other name for mild depression? So you can either put exogenous depression, depressive neurosis, or reactive depression. So in a marital breakup, or when a close friend or relation moves to a distant place, such that the previously close relationship cannot continue, then someone will end up having mild depression. It may also be due to the loss of material possession. For example, when a car is stolen, then the owner of the car becomes depressed. That type of depression is actually exogenous because the cause of that person being depressed is from the outside environment. Or maybe one loses a house through fire or a business collapses, then someone becomes depressed. the type of depression they undergo is actually exogenous depression. Now, what is the etiology of this depression? The cause is actually idiopathic. However, there are a number of predisposing factors to depression. We can have biological factors. What are we saying? Genetics, risk factors such as heritability, meaning that one can actually inherit depression from a parent. There are 40 to 70 chances or percent chances of developing depression from a family with anxiety disorders and neurosis. Sometimes there could be issues to do with neurotransmitters. Imbalance of neurotransmitters, especially serotonin, endocrine changes resulting into hormonal imbalance such as postnatal depression and sleep pattern changes. Last time we discussed mania, we say that someone with a lot of serotonin in their brain being produced, then they will be manic, meaning they will have elation of mood. But someone with less serotonin being produced, meaning that they are likely to develop depression. There are also physical illnesses, especially chronic, severe, or painful illnesses that can also lead to one becoming depressed. There are also psychological factors that may lead to one becoming depressed. Early childhood experiences such as loss of a parent. Automatically, like I've explained earlier, loss of a parent will lead to someone developing mild depression. Lack of parental care. For example, there are those street kids that have not really accepted that life goes on like that on the street. They tend to be depressed first because of lack of parental care. Alcoholism, antisocial traits, childhood sexual abuse, because every time they sit down, they think about what happened in their life previously, they get to feel depressed. It's through the experience they had. Personality traits such as an anxiety, impulsivity, obsessional, and negative cognition. All these are psychological factors that can actually lead to one developing depression. The other factors are social. Remember, psychological factors, they deal with the individual themselves. As they sit down, they think of an event that took place. So it has to do with the cognitive or the thinking of the previous event. Then someone can have what we call the psychological factors to develop depression. There are also social factors. Social circumstances such as marital status affects mental health status. Men have low rates of depression when married. They have more rates of depression when they are single. Whereas women show high rates of depression when they are actually married, because that's when they face a lot of challenges with possibly their spouses. You've seen the difference here. The statement is saying men have higher chances of depression when they are single. When they are married, the chances of being depressed, they go low. However, women, they have higher chances of depression when they are married, unlike when they're single. Usually this comes as a result of marital disharmony, separation, or divorce. So research shows that women having 3 or more children under age 11, lack of paid employment and lack of confiding relationships, adverse life events, in particular loss events, lead to increased chances of developing depression in vulnerable individuals. The other factor that leads to one developing depression is comorbidity. Comorbidity meaning that someone has got one or more sicknesses in them. Depression may exist alongside another mental illness. In about 2/3 of patients, such illnesses include anxiety disorders, substance abuse. That's why substance abuse is not a very good thing. Alcohol dependence, personality disorders. So someone might have one of those, then they may have depression at the same time. That's why I'm saying comorbidity is another predisposing factor. Now, what are the signs and symptoms of depression? Clients with depression, they present with sadness, or they actually appear sad. They have or they feel a sense of being a failure in life. They have decreased libido. They have a feeling of guilty. They also experience self dislike. That's why sometimes they tend to have suicidal thoughts. They have self accusations. Remember, they also experience some psychotic features like hallucinations. So they tend to accuse themselves, oh, yeah, I'm the one who must have done that. I should have done it this way, possibly. They have suicidal ideas. That's why we're saying, as a nurse, you must pay particular attention when you're nursing such a depressed client, because in no time you just find them dead. But the good part is that they usually talk about death before they actually commit suicide. Sometimes you may find them crying because they have actually self-accusation, self-dislike. They end up crying. They are irritable. So as a nurse, you must, as you care for these patients, you must mind the way you approach them. Social withdrawal. You'd find that they actually used to mingle nicely with you before they actually developed depression. But after actually they develop depression, they tend to isolate themselves. And isolation of themselves actually endangers them, because that's when more of the suicidal ideas come into them. Loss of drive, energy, and interest may lead to neglect of family, friends, occupation. So you find that if someone has been working, once they develop depression, because depression somehow disturbs their functional point of individuals. Sometimes, if you're not careful, they may lose their employment because they will not pay attention to occupation. They will lose friends because they will not give the same attention they used to. They will develop anhedonia, in short. Anhedonia is actually that feeling that comes where you tend to dislike activities that you liked before. I'll give an example. This person, before developing depression, they used to love watching soccer with friends, maybe in a pub or somewhere in a public place. But because now they are depressed, they prefer being withdrawn from that public. They would love to be alone. So meaning that they no longer love watching soccer like they used to before developing depression. That is what we are referring to as anhedonia. There will be a lot of indecisiveness in them. Decision making becomes so difficult. Even just reaching a conclusion becomes so difficult with the depressed person. Body image changes. Why? Some of them actually they will not eat because of loss of appetite. So they tend to lose weight. Body image changes. Some of them they will fail to meet activities of daily living like bathing, dressing up themselves. So they will look a bit scruffy. They will look to have changed. That's why we're saying there's body image change. Work retardation. If they used to work or they have an occupation, then they fail to work adequately. They tend to be slow in their work. Sometimes they would stop for some time because they are depressed. They would rather they are alone. They would rather blame themselves. They would rather just cry. Disturbed sleep pattern. They may not sleep for some time, even in the night, because they have a lot of thoughts. Remember, sometimes they even develop psychotic features. They tend to have hallucinations. They tend to have delusions. So they can't sleep. Depressed patients tend to develop anorexia. Hence, they will not eat. And that will make them lose weight. That's why one of the problems you are likely to identify in a depressed client is actually altered nutrition less than body requirement as a result of anorexia. Weight loss may be marked, though compensatory overeating may occur at some point. That's why I find that some depressed clients, they find themselves overeating and even gain weight. I think you've heard of certain people that would say, when I'm depressed, That's when actually I eat a lot. It usually comes as a compensatory measure. Then concentration is poor with a depressed patient. You might think you are giving instructions, and yet you'll be just talking to yourself. Yes, you'll be loud and clear, but they will not get you because their minds usually are somewhere else. They are not concentrating to what you're saying. Motor activities also change. Reduced body movements with phases of locking down. Speech is low, and sometimes there's no speech at all. They experience what we call mutism, lack of speech. These depressed people, because they would prefer they are just quiet, they are just by themselves, they isolate themselves. And that's why now the thought process of suicidal ideas coming. These depressed patients may have agitations, may sometimes be observed in forms of restlessness or fidgeting around. Hallucinations and delusions are present in psychotic depression specifically. What are we saying? In mild depression, you may not find psychotic uh, uh, features like delusions, hallucinations, but they are common in severe depression. They may be in form of auditory hallucinations, where someone is hearing voices that are not even there, accusing him or her of doing something wrong, or they might hear voices calling them, such things, calling their name from a certain direction. Those are auditory hallucinations. They may also experience delusions. Now, let's look at the management of depression. First things first, history. So, history may review mutism, or history may review hallucinations, delusions, such things. You might get history from the relatives. They'll be telling you how this person has been acting up. History may review anhedonia. The diagnosis is based on the criteria documented in the DSM-4. Remember the DSM-4, like we discussed in mania? What is the criteria that should be in the DSM-4 for you to say this is depression? They are saying at least 5 of the symptoms should be present in a client you are suspecting to have depression. So must have been present for a period of 2 weeks at least. Anything less than 2 weeks, you may not call it depression. Represent a change from previous functioning. If someone was functioning very well previously, then after 2 weeks, you notice that there's a change in the way they function. Then you can say someone has depression. One of the symptoms must be either depressed mood or loss of interest in previous pleasurable activities, anhedonia in one way. So what drugs can you use to treat depression? You can use antidepressant drugs like tricyclic, antidepressants such as amitriptyline, hydrochloride. When is it used? Depressive illnesses, particularly where sedation is required, so that someone can rest, can have their thoughts rested. Dosage, you can give 30 to 75 milligrams in divided doses or as a single dose at bedtime or nocturne. Increased gradually as necessary to up to 150 to 200 milligrams. Side effects for this drug, you expect to have dry mouth, sedation, as the name says, antidepressant, constipation, postural hypotension, movement disorders, sweating. The other drug you can use is actually chlorpromazine, also known as Lagactil. This one is actually an antipsychotic, like we discussed previously in mania. Adults, you can give 30 to 75 milligrams per oral in 2 to 4 divided doses. Dose may be increased 20 to 50 milligrams twice weekly until symptoms are controlled. Then in children, give 0.55 milligrams per kg body weight orally in 4 to 6 hours. If you're giving intramuscularly, give 6 to 8 hours, meaning that you can either give it QID or TDS. What is the action of this drug? It exerts antipsychotic effects by most synaptic blockage of central nervous system dopamine receptors, thereby inhibiting dopamine-mediated effects. Remember, we use this drug also in the management of mania. It's the same mechanism of action. Side effects, you notice some extrapyramidal reactions, drowsiness, sedation, tachycardia, nasal congestion, constipation, menstrual irregularities in females, hypostatic hypotension. So what is the nursing implication that you should consider as you are managing these and giving them chlorpromazine? Obtain baseline blood pressure before starting therapy. Watch for orthostatic hypotension. What is this orthostatic hypotension? Blood pressure reducing as you are waking up or standing up from either lying down or sitting down position. Then the blood pressure goes down. That is orthostatic hypotension. So because of that, because of the side effect of hypostatic hypotension, you must first obtain the baseline blood pressure. If you go ahead giving it while the blood pressure is already low, meaning you worsen the condition. You worsen the blood pressure being low. The other drug you can give is haloperidol, still an antipsychotic as well. While giving these antipsychotics, there are those psychotic features, hallucinations and delusions. That's why we're giving antipsychotics. Adults and children above 12 years, the dose varies. You can give 0.50 to 5 milligrams orally. Or if you're giving a TID, then 2 to 5 milligrams intramuscularly or IM. Action has a strong postsynaptic blockage for central nervous system dopamine receptors, thereby inhibiting dopamine effects, same as the previous drug. Side effects, extrapyramidal reactions, drowsiness, sedation, tachycardia, headache, and dry mouth. Nursing implication, you should want to avoid activities that require alertness because it causes drowsiness, and good psychomotor coordination, for example, those that are driving because it causes drowsiness. Tell to avoid alcohol as it worsens drowsiness. If someone is taking haloperidol, then they also go and take alcohol. Then already haloperidol causes drowsiness, then they add on alcohol. It will worsen the drowsiness. Advice to relieve dry mouth by chewing sugarless gum. That will help in relieving dry mouth, because at least as you are chewing, you'll be salivating. The other drug is trifloperazine. In adults, you give 1 to 2 milligrams orally twice daily. The mechanism of action, it has the postsynaptic blockage of central nervous system dopamine receptors, thereby inhibiting dopamine-mediated effects. Side effects, you notice some extrapyramidal reactions, orthostatic hypotension, blurred vision, cholestatic jaundice, urine retention, drowsiness, skin photosensitivity reactions. Nursing implication, keep patients in supine position after administration. Protect patient from light. The other drug you might think of giving is actually profenazine In adults, you give 0.5 to 10 milligrams orally, QID or TDS. Maintenance dose, you can give 1 to 5 milligrams orally daily. Action has post-synaptic blockage of central nervous system, dopamine receptors, thereby inhibiting dopamine mediator effects. What are the side effects for this drug? Drowsiness. You've seen that drowsiness is one outstanding side effect for most of these antipsychotics. Dry mouth, menstrual irregularities in females, gynecomastia in males, inhibited ejaculation in males, jaundice, allergic reactions, tachycardia, seizures. Now, what is the next implication as you manage this client with depression? What should you consider? Want to avoid activities that require alertness because of drowsiness, especially those that are driving. They may just become too drowsy and bash into someone or something. Advice to relieve dry mouth by chewing sugarless gum. Check liver function tests as well. Now, let's go to the nursing management of a depressed patient or depressed client. First of all, you must be able to establish the therapeutic nurse relationship. You don't do so. We have said these patients usually are irritable and they lose concentration. So if you develop a good nurse-patient relationship, they may pay attention to you, or they may actually reduce on their agitation and irritability. So it is important to spend short periods of time with the client in order to minimize anxiety for both the nurse and the client. You can imagine attending to such a patient, even as a nurse, you become anxious. Even the patient themselves, they are anxious, they are irritable. Additionally, it is vital to let the client know when and how long the visits will last. So tell them, I'll only be with you for about 20 minutes or for 10 minutes, then I'll go. Why are you doing so? Because you have mentioned the duration that you'll be with them. They will try to pay attention, trying to count on the period or the duration that you'll be with them. Trust me, after that period you have mentioned, they will lose attention to what you're saying. This is so because clear expectations minimize anxiety with the patient. So tell them, I just want to be with you for 5 minutes. Then you talk to them. You get to be precise in your talking, straight to the point. Otherwise, after the time you have mentioned, they will lose concentration. Always use simple, concrete words and allow time for client to respond. Why should you give them time to respond? Their thought process here is slow because they are depressed. So don't be so fast. Give them time to think through what you have said and to respond. The reason behind is that depressed clients have retarded thinking process and concentration is poor, such that comprehension is also impaired. So every time you're discussing with them, quite right, always be simple in your communication. Concrete words should be used, but allow them time to respond because they have got slow thought process. Encourage clients to verbalize difficult feelings, for example, anger or frustration. Don't sit on their feelings. Let them verbalize. When they verbalize, meaning they bring out what is really bothering them, then it will be easy for you to counsel them based on what they are complaining of. Because if you sit on their feelings, then you may not actually know what is causing their depression. So as to minimize the chance of them being acted out negatively, allow them to verbalize. The other point as a nurse that you should look into consideration is maintaining client safety or safe environment. Why are we talking about this? These guys are irritable. They have got suicidal ideas. They are having hallucinations. They are having delusions. So it's easy to cause harm to themselves or to others. So it's important as a nurse to keep a safe environment where these guys are actually looked after. So adjustments in the patient's environment may be necessary due to the risk of suicide, like I've said. and it may be necessary to improve restrictions regarding bathing and the use of sharp instruments, as well as close observation to ensure that the client is really taking the medication and not holding, later on use the medication to commit suicide. So as a nurse, if you're admitting these patients, ensure that there are no dangerous objects in this room or environment, because they may just easily use them to harm themselves or harm another person. You should also closely monitor the patient so that every time they start talking about suicidal ideas, you quickly come in and intervene. When you give them drugs, ensure that they have taken them, or else if they keep them, they may take them later in the wrong dosing and end up killing themselves. So pay attention to the environment where you're nursing these patients. There should be no injurious objects, because they may just use the same object to injure themselves or others. Pay particular attention to them, especially what they say, because if they talk about suicidal ideas regularly, then it's likely that they may actually commit suicide. Every time you give them medication, ensure they take it, because if they keep it, they'll keep piling it and take it in bulk at once, and then they'll kill themselves. So a contract can also be signed with clients to ensure that the client does not take any action meant to harm self or others, meaning you admit them. As much as safe environment is good for them, what is the best position for a depressed patient or client? Patient can assume any position of choice just for their comfort. Don't restrict them too much. Remember, these guys are actually agitated, irritable. Observations are important also to conduct on these patients. Observations of vital signs are done. Blood pressure, remember you're giving them those drugs that actually lower the blood pressure. Check the blood pressure, respirations, pulse, even temperature. Observe the patient's mood changes, very important, and assess closely for any signs of them wanting to kill themselves, and take action by not leaving the patient unattended to for a long period of time. That's why I've actually said closely monitor them, hear what they say when they are alone, because once they start talking about suicidal ideas, then you should know that anytime they may commit suicide. So observe their mood changes. Observe and hear what they say. Observe their feeding pattern, because we have said these guys tend to be anorexic, they lose appetite. So observe their feeding pattern. If it is poor, encourage them to eat small but frequent meals in form of snacks, especially to allow food intake, so that we don't have them losing weight after some time. Psychological care is very important in this patient. So this patient needs a lot of counseling under this one. So meaning that you have to identify what should be causing the depression. Then sit down with them, counsel them. The depressed patient may gain comfort from reflecting on the fact that we all, on one occasion, commit acts which could be described as bad. Because depressed patients, then they feel that it's only them that have committed such an offense or a crime. That's why they tend to feel it's worth killing themselves, because they cannot be accepted in society because of what they've done. They have that feeling of being stupid, a failure. But this does not make us a bad or stupid person, because we've also felt like that before. You counsel them, talk to them. You're not the first and only person who has felt like that, so that they can actually know which decision to take and forge ahead with life. We learn from the mistakes. Tell them that. We learn from the mistakes that we have made in life, and will inevitably continue to make them. Life is full of mistakes, tell them. We do make mistakes on a number of occasions, all of us, and they'll always be coming. But we must learn to judge the act rather than the person making that mistake. Counsel them in that way, so that they can understand that actually mistakes in life, they're inevitable. However, life has to Forge ahead. The depressed patient should also realize that self-worth is not determined by external achievements and competencies, but it's about how you're feeling yourself. Achievement does not always bring happiness, remember? They should know that. There are many successive and miserable people around the world. A depressed patient should know that so that they actually realize that they're not the only ones feeling like that. Being accepted by fellow patients and by nursing staff on the basis of positive aspects of self may promote awareness of this important fact. Nearly all instances of unhappiness are due to internal thoughts rather than external thoughts. Why? And this is in accordance to Ellis, 1962, meaning that the way you feel internally is what will determine how happy you will be, not the external forces, but how you feel internally is what will determine how happy you will be. Elimination. It is important to monitor intake and output of fluids with these guys. Remember, they are depressed. Sometimes they wouldn't even love to take water. And especially also monitor the bowel movements. So foods rich in fiber as well as exercises should be encouraged to prevent constipation, as it can occur mainly due to underactivity. Even fecal impaction may result. So they should also take a lot of fluids to avoid constipation, fecal impaction, all those. Nutrition. We have actually mentioned that these guys have anorexia. So anorexia is a common thing in depressed clients, and therefore it is necessary to offer small, high-calorie and protein snacks frequently throughout the day and the evening. Remember, they need to have energy. They need to have a lot of proteins. Poor nutrition renders the client susceptible to illness. So small frequent snacks are more easily tolerated by a depressed client than large amount of food when one is anorexic. Also offer fluids frequently during the day and evening to prevent dehydration. These people that are depressed have actually mentioned that they develop insomnia. Their sleeping pattern is disturbed. You may find actually that they wake up very early in the morning, maybe around 3 or 2. So observe for insomnia or early morning waking. It is important for the nurse to provide rest periods after activity. So during the day, maybe they should not sit on their sleeping areas or bed. So at the moment they see the bed in the night, they know that it's time to sleep. Fatigue can intensify feeling of depression sometimes. So that it's important that they rest. Encourage the client to stay out of bed during the day, like I've already said, so as to increase likelihood of sleep during the night. Furthermore, provide relaxation measures during the evening and reduce on environmental or physical stimulants. Hygiene. These guys, they have issues to do with taking care of themselves. There's altered hygiene in them. So if there is evidence of self-neglect, as is common in most depressed clients, the client needs to be helped on his or her self-care with regard to hygiene. Encourage them to bath, help them dress up on their own, encourage them to brush their teeth. This can be done by providing toiletries to the client, as well as keeping on reminding the client to undertake the tasks needed in this area, like bathing, we have mentioned, brushing of their teeth, spreading of their bed, and just cleanliness on their surroundings is very important. Sexuality. If this client is actually married, assess and reassure the client of any changes taking place in their sexual life as a result of depression. You have to counsel them in line with sexuality. This will reduce antidepressants may be used. This will reduce the client's anxiety and assist support compliance to treatment or medication. Physical activity and recreation, very important. Remember, these guys, they have developed anhedonia. They used to love watching or participating in certain activities before they became depressed. But because of depression, they have developed anhedonia or they have become anhedonic. While the client is severely depressed, one-to-one activities are appropriate because concentration is impaired. Potential for interaction is maximized and anxiety levels may be minimized. The nurse should use activities involving gross motor activities which call for minimal concentration. For example, taking a walk, making beds with the nurse, setting up chairs, etc. and etc. A depressed client may easily participate in such activities. Physical activities are known to relieve tension with them, so it's very important to involve them. Sometimes you may involve them in certain games, netball, football. That actually helps to relieve tension. For a severely depressed client, it is better to provide activities that require very little concentration. For example, simple card games, the way people would sit down and play games, looking through a magazine, just looking at the pictures, the diagrams, all those. This is so because concentration and memory is impaired in a severely depressed clients. Lastly, there is need to bring the patient into contact with one another. Remember that they would love to be isolated on their own, or they will isolate themselves. Social interaction is actually impaired in these people because of their thought process, hallucinations, delusions. So there is need to bring the patient into contact with one another person and then into a group of more than two. Slowly, you integrate them like that. This distracts the client from self-preoccupation and provides opportunity for spending time with other people and activity is based on reality. It also raises the client's self-esteem, which in most cases is very low in depression. So group discussions, dance therapy, and art therapy can assist to achieve this. Medication, what should we ensure it should be done in terms of their medication? Ensure the patient receives the prescribed drugs to promote recovery and observe for any side effects of the drug. And if you notice any side effects, then quick interventions should be brought in to avoid worsening of those side effects. Preparation for discharge. Remember, these clients actually admitted. Clients' preparation for discharge, which should have begun in the initial phase of client's admission to hospital, should be re-emphasized to client and his family. Educate the client and the family on the early signs of relapse of the disorder for quick intervention. Once they know that these signs and symptoms the client is presenting with while he's having been discharged from hospital, they know that these are depressive signs and symptoms. They will quickly bring the patient back to the hospital and there will be quick intervention. So you must educate them on that condition. Make the client and family understand the medication regime so that they don't abruptly stop, or so that they can be at least compliance of medication while it's at home. Timetable and its side effects to make adherence to treatment possible before discharge. You must ensure that this is given to them. This helps on improving on the knowledge levels of the client and family with regards to the illness, and in turn reduces the anxiety and the lapses of depression, because the client themselves and the family, they'll be knowledgeable of depression and how to manage it. If you are using the nursing care plan, here are some of the problems that you may actually identify. What we are using previously was what we referred to as the general nursing care. It is specific, yes, not written in the table form. But if you're using the nursing care plan, here are some of the problems that you may actually intervene on your own at your own time. One, someone with depression may develop risk of suicide related to depressed mood, feeling of worthlessness. So depressed mood, feeling of worthlessness, punitive superego, irrational feelings of guilt, numerous failures, hopelessness, delusion, thinking, and hallucination may actually bring about suicide. That's what we're saying, risk. Remember, this is a potential problem. That's why it begins with the word the risk. There can also be dysfunctional grieving related to real or perceived loss, bereavement, overload, etc., etc., evidenced by denial of loss. They will refuse actually that there is this loss. Difficulties in expressing loss, labor or affect. These clients may also have self-esteem disturbance related to lack of positive feedback. That's why it's good to give them positive feedback. Oh, you're looking great. You're looking nice when they put on certain clothes. When they do something good, compliment them. Then like that, they'll actually have self-esteem. So self-esteem disturbance related to lack of positive feedback, feelings of abandonment by significant others. That's why I'm saying you have to be close with them and monitoring them. Evidenced by difficult accepting positive reinforcement, being highly critical and judgmental of self and others. They may experience social isolation or impaired social interaction related to fear of rejection or failure to interact, evidenced by sadness, dull affect, seeking to be alone most. They may have altered nutrition, less than body requirements related to depressed mood, loss of appetite, ideas of self-destruction, evidenced by loss of weight. They may develop pallor. If it's a female, they may have actually amenorrhea. That will tell you that actually there's a problem with their nutritional status levels. Sleep pattern disturbance may be present related to repressed fears, evidenced by verbal complaints. That's why we actually say pay attention to their complaints so that you pick up what they are complaining of. Possibly that is what could be causing them being depressed. So sleep pattern disturbance related to repressed fears. Remember the word depression from psychology. Under defense mechanism, you discuss repression. Evidenced by verbal complaints of difficult falling asleep. Then there can also be self-care deficit related to depressed mood, anhedonia, all those things. Evidenced by the patient or the client looking untied and scruffy. Now, how is the prognosis of depression? Depression is a treatable illness. About 65% of patients respond to treatment, especially antidepressants. 85 respond when given antidepressants and psychotherapy. So it's very important. Other than just giving antidepressants, you also add psychotherapy. That is according to Saunders, 1997. So today's discussion was on depression. What we defined what depression is. We also looked at the types of depression. Mainly, we have said there is severe depression, also known as endogenous depression, also known as psychotic depression. There is also mild depression, also known as exogenous depression, also known as reactive depression, where we say the reactive depression is coming about because an individual is reacting to a certain situation or external environment. What has happened? Well, given an example of someone losing a loved one, then they get depressed out of that. That's why it's known as reactive depression. Psychotic depression or severe depression is known as that because it actually presents with some psychotic features like hallucinations and delusions. That's why we also end up giving antipsychotic drugs like haloperidol. We also looked at the predisposing factors to someone developing depression, where we say there's hereditary connection, there are psychological factors, social factors, comorbidity issues, and bio factors like the issues in line with the levels of serotonin and dopamine in someone's body. We also looked at the signs and symptoms of depression. One of them we actually said poor social interaction, poor concentration, anhedonia, crying, being sad, hallucinations, and delusions in psychotic depression. Management, you can use antidepressants and psychotics like that. You also add psychotherapy in the management of depression. Then we also looked at the nursing problems that you can actually identify with someone with depression. Lastly, we looked at the prognosis, where we said if you only use antidepressants, you might manage 65% of the depressed patients. But if you also add psychotherapy on top of antidepressants use, you actually manage 85% of cases of depression. Thank you so much for listening. And I would say, it was a weekend to you all. In my mother tongue, we'll say, Dalumbagapati, meaning thank you so much.